Once again, we focus on COVID-19 in North Carolina with DHHS Secretary Mandy Cohen. Welcome again, Secretary Cohen. This is week 6 in our visits. When we first started March 5th, you reported we had 6 cases of coronavirus. We're now into the 7,000s. We have seen this blossom and bloom and boom over those weeks. Last week, you came in with some sense of optimism from the standpoint of maybe the doubling rate was calming down and slowing down some, but it seems like in following the numbers over the last few days that it's just exploding again. Is that an accurate reading?
So I think we're somewhere in between that. I am still optimistic. I'm still grateful for the work that everyone is doing around North Carolina to slow the spread of the virus. I know staying at home is tough on every single family, on businesses. We all want to get back to our regular lives. But what I would say is all this hard work is working. So we are slowing the spread of the virus. We continue to see a slowing of the doubling time, which is really good.
Yeah.
And we are seeing that slowing. However, you are right. We are not seeing a decline in cases. We're not seeing a decline in hospitalizations. And so what I think where we are as a state, we are leveling. We are plateauing, which is exactly as you think about a curve. We're at that plateau of the curve. We did exactly what we said we wanted to do, was flatten the curve. So we've never gotten a big spike, a big surge. And I think that's a good thing. Now the question is, how do we maintain it or drive it further down? And I think that's what we're focused on now.
Currently the doubling rate is like 12 days. Is there an optimum you're looking for, like 15 or 17 days over an extended period of time?
So what we're actually looking for is the case counts to go down. So doubling time still implies that we are increasing. And if you look at even the White House guidance that was put out last week, they talk about a 14-day trajectory of downward cases. So we have not seen downward yet. So doubling time indicates that we're still on the upward swing. What I'd like to see us, and as you increase the doubling time, it means you're flattening the curve or plateauing or leveling. And I think that's more likely the scenario that North Carolina is in. But the White House guidance is very clear about wanting to see a downward trajectory, and I have not seen that yet here for North Carolina.
And it seems like some states aren't paying much attention to that directive anyway. In a recent press conference, you were talking about contact tracing. Explain that to us and who is doing it, how many people are involved, and what we need to have.
Sure. Contact tracing is something we've been doing from the very beginning here in North Carolina, and it's been done well before COVID-19. It is when we see someone test positive for COVID-19, and then we have folks that are embedded at our local health departments, that they go and they interview that person who was positive. They go through their calendar and maybe even their Facebook feed to say, where have you been? What have you done? And then who might you have come into contact with that you could have potentially spread this virus to? And again, they try to spread that into risk. So it's not anyone ever that you've come into contact, but what are those high-risk contacts? So first, who lives in your home, right? That's the highest risk contact. Second, who might you have been in contact with over a prolonged period of time? So within 6 feet for more than 10 minutes. And again, that's where the guidance, so that's a medium risk. And then low risk, as we've always been talking about, maybe you've been to the grocery store and you've walked through the aisles. Now that's a low risk exposure, but obviously there is still some risk there. So our contact tracers do the work of identifying high risk, medium risk, low risk, and then work to contact those people to tell them that they may be at higher risk.
How does that help us?
Right, so it'll allow those people who might be exposed to be very aware of their symptoms. If it's a high-risk person, we may even have them quarantine. That's when someone who's not showing symptoms, we ask them to stay at home and not go out. So if it's a truly high-risk contact, we might ask them to quarantine for a period of time so that they, even if they're not showing symptoms right now, we don't want them out and about shedding virus. For some of those medium contacts, it may be that we ask them to monitor their symptoms really, really closely so that they don't have a period of being out and about infecting others. So it's a really important way for us to make sure that we are kind of getting a little bit ahead of the virus and how it spreads.
And you mentioned we had about 250 people currently doing this, but that you wanted to ramp that up. How many do you think we need?
I do. Yeah, so we're trying to analyze that right now. What we want to do is certainly increase that workforce capacity. And remember, our local health departments have been at this for many months at this point, and so they need reinforcements. And so we want to tuck some of these new people that we would be bringing on into our local health department infrastructure to have them embed into this work and just give them the opportunity to do more. Because look, we know there's more virus here, and we know as we think about reopening efforts that there may be more spread of virus,
yes.
But if we can stay a little bit ahead of it, that's the important part.
And we're reporting more than 7,000 cases, but the fact of the matter is we don't really know how many cases of COVID-19 there are in North Carolina, do we?
So right, the 7,000 number is lab-confirmed cases. Any one of these metrics has its limitations, right? So all we know from that number is how many people have come to medical care, gotten tested, and then came back positive. We know that there are folks out there, one, who may just not have symptoms, so they're not getting tested, but also for a while, as we were responding to this crisis, we were very low on testing supplies as well as personal protective equipment. So we really prioritized testing just for folks who are hospitalized, who are healthcare workers and in outbreak settings. And so we know there was a number of folks who were sick that rightly recovered at home, but we did not capture in our numbers. This is why we've been partnering with academic partners around the state to really help us get a good sense of virus. We want to know who currently has the virus right now, as well as maybe folks who may have had it in the past and have already recovered.
So we've tested about 86,000 completed tests as of the time we're talking, which is frankly less than 1% of our population. About 2,500 people a day are being tested. That needs to be ramped up also, I think you've said.
Absolutely.
What's the ideal number there?
Testing is so
500, 5,000 or what?
So I think that we definitely need to be doing more than 2,500 tests a day. And we are already starting on that path to sort of ramp up our testing, and we're already seeing some increases in that. We've changed our guidance to providers. We've said, hey, we have more testing supplies, we have more protective equipment. We want you to use your clinical judgment and for folks who do need a test, they should get a test. Use our private partners. LabCorp has been a terrific partner with us, but also all of our hospital labs, various ones have capacity. What we're learning from our testing surge work group is that we have capacity here in North Carolina, but it may not be appropriately deployed, meaning that we were talking that we have a lot of testing capability in the Triangle area, but the Triad needs more testing capability. So how do we share resources across regions? And I think that's the work that's been going on over the last week, and I'm already seeing some of that really benefit folks across the state.
Help us understand testing. We hear a lot about testing. And the little research that I've done says that there's molecular testing and then there's serological testing. Explain the different kinds of tests to us.
Sure. So first, there's testing of someone who may have active disease. They have COVID-19 right now, and that means that they have virus in their body, so that the virus is in their saliva, it's in their nose. That's why we take a swab, which calls a nasal pharyngeal swab. We're trying to pick up virus from back in their body and make sure we get the virus onto a swab. We take it to the lab, and then we do something called PCR, which allows us to look for the viral RNA and say, is there virus present or not? And if there is, you're positive. If there isn't, you're negative. And so that is when we say testing, that is what mostly I am talking about. Active disease and picking up, do you have virus right now? The other kind of testing is saying, did you have COVID-19 in the past?
And maybe not even know
your body
it.
can tell, and you might not have even known it. But some people say, I had a cough and a little fever back at the end of March. Was that COVID-19? I don't know. Maybe my dad might have said that to me. And I'm like, Dad, I don't know if you had it. But, right, I said, protect yourself, Dad. I don't know if you've had that.
Wash your hands.
But exactly, wash your hands, Dad. But we have a blood test that can look back and look in your blood for what's called antibodies. When we are exposed to a virus, our body responds, our immune system responds, and it creates antibodies. So we can look for those antibodies, and it can let us know, yes, I see antibodies to COVID-19. That means you had it in the past. The problem with serology that we are seeing is antibodies can be very non-specific. It's actually pretty hard to pick up COVID-specific antibodies. We're picking up coronavirus antibodies, but remember, we talked about there's 7 types of coronaviruses out there, so we want to make sure we're picking up COVID-19 and not the common cold, right? So we want to be sure we're specific, and so the serology test is still maturing. It's still evolving. There's only a few that have been approved by the FDA, though the FDA is allowing folks to be on the market. Understandably, we're in an emergency, so they're trying to get everything to market quickly. But that's where we have some more work to do on the blood test to make sure we get to ones that are really well suited to identify COVID-19. That's the work scientists are doing right now.
So if I've got COVID-19 antibodies, does that mean I will not get actual COVID-19? I've already had it. I can't get it. I'm not contagious?
Right. So it means it does confer immunity to COVID-19 for you. The question is, for how long? I think that is a question that we don't know the answer yet. We know that once you have COVID-19, you do have some period of immunity, but this is also new, so we have to keep watching folks to see how long that immunity, will those folks need to get a vaccine as well, or some sort of booster for their immune system. So that's still unknown, but yes, it confers immunity at least for a period of time.
And I'm reading about, you talked about the nose swab, but also saliva. Is there one that is more efficient, more effective test than another?
So we've heard about one saliva test that's been approved by the FDA. It's only being used, as far as I'm aware, at Rutgers in New Jersey, and it has not been replicated for larger mass production yet. We in North Carolina, as far as I'm aware, in our labs, we have not been able to validate a saliva-based test, meaning that when you just take saliva, you don't get enough virus in just the saliva alone to be able to know, yep, there's virus there, or no, there isn't. And so I haven't seen that here in North Carolina, though those are the kinds of things that we're hopeful, because the more we can move to a saliva or even just a nose swab instead of a nasal pharyngeal swab, it uses less protective equipment for our healthcare workers, and that's good overall, because we know we've had not enough gowns and gloves and masks for everyone. So we want to move to those kinds of tests, but we haven't really seen that really play out yet, but I'm hopeful that we can see more of that on the market and working consistently.
And you mentioned LabCorp. They just announced in the last couple of days, they've come up with an at-home test. And you can do this at home. Now, they're saying it costs about $119 for this test. Any idea whether the insurance companies will pay for that or not? Or Medicare, Medicaid?
Well, so I assume that most will cover testing. Almost all of our insurance companies, including Medicare and Medicaid, have said they were going to cover COVID-19 testing and do that without cost sharing. So I would assume that would include the home test kit. But I know LabCorp also said that they are still in a smaller supply, so they're trying to reserve those home kits for, I believe they said, healthcare workers and another cohort
high
of folks.
risk.
It was sort of, they tried to narrow it. High risk, thank you.
Yeah.
And so, we are definitely in conversations with them to understand what can we, how could we partner with them for here in North Carolina for that test. Because again, that's great. We want to see more tests that we can do at home. Again, it doesn't risk people coming out of their home and potentially spreading virus. It doesn't require any PPE. So all that's great. But it sounds like they're still ramping up the production of those kits, and so we'll see more of them come online, I assume.
So we talked about antibody test. How about someone who tests asymptomatic? Is that the same thing? Explain that difference.
Yes. So someone could have symptoms or not. If they have symptoms, it's usually things like cough and a fever. Sometimes they lose their smell or their taste. Other folks could be having the virus, but they're walking around. They have no fever. They have no cough. But they could be asymptomatic, but carriers, meaning if you actually swabbed their nose or their nasal pharyngeal area, you would actually find virus. Now, but the issue is people could be asymptomatic and not have virus. You don't know, right? They're asymptomatic. And so what we need to do is differentiate between someone who has no symptoms and is carrying the virus and someone who has no symptoms and isn't carrying the virus. And it's hard to know how to find those folks. What we're seeing as we have some of our outbreaks, either in nursing homes or in our correctional facilities, when we go and then as a preventative measure, we test everyone, that's when we're picking up a lot of asymptomatic people. But that's a very controlled and confined area where there's known to be a lot of viral spread. The question is, how much asymptomatic spread is in the general community when everyone's walking around living their lives? That's unclear at this point. We know clearly there is some, but we don't know yet how to best estimate that, but we know that there is some.
You talked a little bit about recovery in one of your recent press conferences. I assume recovery means I'm over this. I'm not contagious anymore. What's the definition here? I mean, does it mean that if I am in recovery, that I'm not contagious, I'm not going to get it anymore, or what does that mean?
Yes, so we know people have recovered from COVID-19, which is great. And recovery, we have defined how to tell when you can release yourself, if you will, from isolation. So we have guidelines. You do not need a test to say I can come out of isolation and I'm from COVID-19. It says that you need to be in isolation for at least 7 days, or you have to see your symptoms stop and then wait another 72 hours. So you need your fever to stop, your cough to decline, you to actually feel better, and then wait another 72 hours. And then we feel comfortable that we can call that, yep, you can come out of isolation now. You're not going to be contagious to other people. That's different than defining, well, how many people have recovered, right? Unless I call every single one, I don't know when their symptoms go away. We know when we've gotten their positive test, but the duration of disease is very variable. Some people are sick for a week to 10 days. We're seeing others who are sick for 3 to 4 weeks. And so it's really hard to define a number and say, okay, if we've had your positive test for 3 weeks, we're going to consider you recovered. And that's the reason why we haven't been able to report a recovery number.
I was going to ask you about that.
How do you define that in an aggregate way? It's hard to know.
And some hospitals and some counties report those numbers and some don't.
So yeah, and the problem is we're getting into an apples and oranges because everyone's defining it slightly differently. That's why we have asked the CDC for guidance. I'd like the CDC to put out one way of defining recovery, and then we'd be happy to calculate that based on it. But it's so variable. Like I said, we see folks in a hospital for 3-4 weeks, unfortunately, with recovering from this. And so it's really hard to put a number and say, okay, I can declare everyone recovered if it's been 21 days or 30 days. So we'll get there, though.
And we have to keep reminding ourselves. Alan Dobson with CCNC did a piece the other day, and he said, we've never seen this before. This is totally new territory for us. We have to understand we're plowing new ground with just about everything that takes place. I know y'all are under an awful lot of pressure. about relaxing the restrictions. It's a topic of discussion. There are protests that are taking place. Tell me what you're looking for to recommend to the governor relaxing or easing these restrictions. What are the specific things you want to see?
Yeah, so we laid out a framework last week of how we are going about looking at various pieces of it. Importantly, we're looking at trends, the trends in our data, and specifically looking at things like lab-confirmed case rates. But we know all of that, as we talked about earlier in the show, lab-confirmed case rates are limited, right? We're not capturing everything. So you can't look at that alone. So we need to look at lab-confirmed case rates. We need to look at the percent of positive of tests in the scheme of the whole test. We have to look at hospitalizations. We have to look at our syndromic surveillance. That's us trying to catch things even before we get a positive test. So those are the kinds of things we're going to want to look at. And the White House gave us guidance last week on what kinds of direction they want to see in those figures before we would move to reopening. So that's one piece. So we said trends, very important. Obviously, we talked about testing already and needing to ramp up testing as a capability that our state needs to have. I think we have good progress there. And then the tracing piece. So there's capabilities we need. In addition, I'll add another one, which is around having the personal protective equipment. Because imagine we loosen things up, the virus spreads a bit more, and we do get a surge at our hospitals. I need to make sure that our hospitals are ready to handle it, not just from a space perspective, having enough beds and enough nurses and doctors, but they have to have enough gowns and masks to be able to do that work. So there's an element of needing the protective equipment. But I think all of things are trending in the right direction in terms of PPE tracing and testing. On our trends themselves, you could just look at our website to see those numbers. Like I said, we're kind of leveling. We're not going down yet. And so I think we're doing good work, but we're not quite there yet.
The governor has indicated he's going to be making an announcement, and I'm sure you're whispering in his ear during the course of this. But there's some states that are just relaxing almost all restrictions. I'm thinking about Georgia, South Carolina even. Yeah. What's your reaction to this at this point?
Yeah, so when I even look at the difference between what South Carolina did and Georgia, I think they're very different. And they each have to look at their own numbers and make decisions based on those numbers, and I hope that they are. But South Carolina even did very, modified, pretty small amount of changes, where Georgia, wow, there were a lot of changes that he's proposing to do immediately, right this weekend. And as a neighboring state to Georgia, I will say that makes me incredibly nervous, right? Because if they see a lot of virus, that there are a lot of folks who come between Georgia and North Carolina. That means more virus coming into our state as well. Yeah. And I know our folks in North Carolina have been working so hard to stay at home, to slow the spread, to get ready. So I'm a little concerned by that.
This virus doesn't know geographic boundaries. They don't know when we cross the state line.
They don't care that you lived in Georgia one day. No, that's exactly right.
Governor Cooper has said that this is not going to be like throwing a light switch. It's going to be more like a dimmer. Explain what he was talking about.
Yeah, so if you imagine stay at home as the lights being off, and sort of what we imagined back from January and what our lives were in January being on, we know we can't stay at off where we currently are, stay at home forever, but we also know that going back to what our lives were in January is not realistic. This virus is going to be with us until we have a vaccine. And so the question is how can we safely keep the virus under control and use particular kinds of mechanisms as we try to slowly move from off to on. So what are the first things that we could try to do that will allow us to also get used to some of the social distancing in our everyday lives? So we've been staying home, but we need folks, as they think about going back to their lives, as they think about going shopping, they're practicing this in going to their grocery store, staying 6 feet apart, making sure they're washing their hands good, that we're doing deep cleaning, all of that. But we need to see that at all the retail establishments.
So we're going to be
likely,
easing.
to make sure we're protecting ourselves.
You think we're going to be easing into these restrictions? Is what it boils down to. Do you foresee?
I think we are, and it'll be in phases.
Do you foresee we will be asked to wear a mask or gloves or any kind of things like that?
So face coverings has been a topic of conversation here amongst my team. So the CDC has recommended face coverings,
Yes.
which I differentiate from face masks. So face coverings for folks who think they may be in public spaces where they're not going to be able to social distance. And remember, those kind of face coverings are really more to protect the world from you. So you may have virus and not know it, and you don't want to spread it to the world. So it's really protecting the world from the wearer of the mask, and so, or the face covering, I should say. And so, the data really is mixed, because we worry about with face coverings is people forget the tried and true things like washing your hands. They'll be like, cool, I got a mask on, I'm safe, I'm good, and they forget to stay 6 feet apart. They forget to wash their hands, and the other stuff that actually has real evidence-based data behind it. So so it's not that face coverings are wrong by any stretch, and I think that they are a good addition when people wash their hands and stay socially distanced.
Understanding their benefit. I got about 30 seconds left.
And I will say gloves is not a thing. Gloves, I think, also lulls people into false security. Then they touch a lot of things, and then they actually can move the virus from one place to another.
With their gloves.
I'd rather folks no gloves, wash your hands.
I got about 30 seconds left. Final word to the people of North Carolina.
Gosh, I've said wash your hands a lot during this time, but I wanted to say just thank you. I know this is hard. I know we're frustrated. Folks are cooped up, and kids are home from school, and life feels very, very
And we're looking forward to
different.
that.
Folks have lost
Secretary,
jobs, and gosh.
Thank you again for visiting with us. Look forward to next week.
Quality public television is made possible through the financial contributions of viewers like you, who invite you to join them in supporting UNC TV.